So hi everybody, thank you for coming again to hear me. I'm conscious that I have quite a strong Australian accent, so sometimes it's a little bit difficult to understand me. So if there's any problems in terms of you not understanding what I'm saying, please put your hand up and let me know. Particularly in the workshops, I try and be quite informal. Often, if it allows, then I would come and sit with you and have a discussion, but unfortunately because of the filming, I have to be up here. But please do jump in. The idea is that this is not a lecture, it's different from this morning. So if you've got questions, put your hands up at the time and we can have a discussion about it. And if it's okay with you, the kind of structure that I've worked out is to talk through some case studies so that hopefully we can talk about some of the issues in managing women with diabetes in pregnancy. And the idea is that it's a two-way discussion because I'm learning from many of you just here this week that there's quite often quite big differences in terms of the way that we manage these women in pregnancy. So I'd like to learn from you just as much as hopefully I can share something that's useful for you. But it only works if we go both ways and if you are not afraid to let me know what you're thinking and put up your hands. Does that sound okay? Fine. The other thing is I've got a couple of case studies and a couple of things to talk about, but if there are any questions from this morning or any particular topics you'd like me to focus on, the idea is that this is useful as possible for you, so do just ask me and we can talk about something else instead. Okay? Yeah. 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 Do you mean when they're already pregnant? Yeah. So. Yeah. 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 So I think the question is if you have someone who's pregnant with the levels of impaired glucose tolerance, yeah, and what to do, whether to take an HbA1c or glucose tolerance test and how you. Yeah. So is this somebody that had impaired glucose tolerance before they were pregnant? Or only once they're pregnant? She's pregnant, okay. So I would manage it slightly differently. If that was the problem before conception, then I would treat it like someone with type 2 diabetes because it's likely to get worse in pregnancy. If this is a new problem in pregnancy, then it depends how you figured it out. Usually we would still do a glucose tolerance test, but with everybody who has a positive glucose tolerance test in our centre, we do an HbA1c as well. So we do both tests to give us an idea of how long the glucose disturbance has been. The range of impaired glucose tolerance outside of pregnancy, the range that we normally talk about, would be equivalent to gestational diabetes in pregnancy anyway. So any glycemic disturbance really becomes GDM in pregnancy anyway, so you would manage it the same way. Does that make sense? Answer your question? Fine. Okay, so let's get started then with the first case study. So this is a 39-year-old woman who came to us. She had one previous normal vaginal delivery and long-standing problems with fertility. Tried to get pregnant for a long time. In the end, she was successful with IVF, so this current pregnancy is an IVF pregnancy, and her BMI is 29, so fairly typical, at least in our centre. Many of the women are overweight. This is not an unusual story, right? So what information at this point would you like to know in terms of being able to decide what to do from here? Yeah, so some information about her previous pregnancy would be useful. Are there any specific things you might like to know? Yeah, so at the moment this woman does not have diabetes. So you want to know if she had GDM in the past pregnancy, yeah? Pardon? Family history of type 2 diabetes, presumably, yeah. Pardon? I'm sorry, I'm struggling to hear you a bit. I don't know if there's a microphone maybe. Previous diabetes with pregnancy, yes, sorry, yeah, absolutely. And the other thing I don't know if you remember from this morning is how big the baby was. Even if she did not have diabetes last time, if she had a big baby, then that's relevant. And sometimes people don't know exactly how much their baby's weighed or they get it a bit wrong. So asking other things too, was there any problem getting baby out? Shoulder dystocia? Was it a cesarean section or a vaginal delivery? Those sorts of things, yeah? And whether the baby was okay afterwards. Fine. So here's some of that information. Her last pregnancy was 3 years ago. She did not have gestational diabetes, but she had a big baby, 4.1 kilos. She does have a bit of a family history, so her mother had diabetes in pregnancy. She's got 2 grandparents and an uncle with type 2 diabetes. Okay? So, we talked this morning a little bit about the different types of screening programs. So I'm interested to hear from you. What would you do in terms of screening this woman? Do you have a GDM screening program? 24 to 28 weeks, yeah. Okay. So would this woman count as high risk or low risk? High risk, yeah, exactly. So you'd do it at 18 weeks? Yeah, and what would you do at that point? First presentation, so there's a couple of different things. So first presentation, or let's talk about the timing first then. Who would do it on first presentation? Yep. Who would do it at 18 weeks? No. 24 to 28 weeks? Okay. I think the practice differs, so there's not necessarily a right or wrong answer. We would do it earlier, but then if it was negative at that point, we would repeat it at 24 to 28 weeks, yeah? And what about in terms of how we screen it? Would you do a fasting plasma glucose? No, HbA1c? Pardon? Or oral glucose tolerance test. Anybody do a glucose challenge test, which is a non-fasting? You would do a fasting. And does everybody have access to be able to do that for whichever patients they like? Yeah? It's possible to do that for every patient who is high risk like this? Yeah? Okay. Yeah. Yeah, exactly. Yeah. So, I mean, that's basically what we do. So we would do it at first presentation with a glucose tolerance test, and then if it was negative, we would repeat it at 24 to 28 weeks. But there's quite a lot of differing opinions. So some people would say do an HbA1c or a fasting glucose at booking, and that's it. And if that was normal, then they would do the 24 to 28 week oral glucose tolerance test. I think it depends on what resources are available at your centre. So not everybody has access to be able to do the full expensive 3 blood tests for every patient. Out of curiosity, do you screen everybody at 24 to 28 weeks or only those women at higher risk? All pregnant women. Great, yeah, that's what we do too. But it's not what's recommended in the UK. So our centre is a little bit different from the rest of the UK. Fine. So this was her oral glucose tolerance test results. Because we use the IA-DPSG criteria, she is diagnosed with gestational diabetes here. What does everybody think about that? Pardon? What are the, are you talking about different glucose? Yeah, you use I'm sorry, I don't know the conversion. Basically, the fasting glucose is just very mildly elevated above the cutoff. The others are within range. I'm sorry, I don't know the conversion. Yeah, it's about, yeah. Right, yeah. I'm not very good at mental arithmetic. Yeah, so I think that's about 100 and something, isn't it? Perfect, great, 100.8. Perfect. Her fasting is 100.8. Thank you. And the other 2 are normal. Okay? But you can see that the 1 hour reading is almost 180. Yeah? So it's normal according to the criteria, but most pregnant women still would not have that rise. Yeah? So it's somewhere in between. But it's because, if you remember, we've chosen these cutoff criteria relatively arbitrary. Yeah, there's a continuous association between glucose and adverse outcomes. So we have to draw a line in the sand somewhere and say, this is normal, this is abnormal, and it's a bit of a guess. So this woman is probably, she's a bit on the borderline. Her fasting is a little bit too high. The other ones are close to the limit, but okay for now. So, yeah. They are. In pregnancy, though, that first reading classes as gestational diabetes. Yeah. So just one abnormal value means diabetes in pregnancy, but it's likely to go away afterwards, yeah. So what would you do at this stage? Assuming, even if you have slightly different criteria and this woman didn't have it, assume that she's diagnosed with gestational diabetes, but relatively mild. Lifestyle, yeah. So what sorts of things do you include in that discussion? It was 29, yeah. So diet, yeah, exactly. And what sorts of information do you give about diet? Is that something that you do yourselves as doctors, or do the dietitians do that? Nutritionists? Yeah. Does anybody know what's included on that sort of list or in that education? No. So you do it yourself? Right. So what sorts of information would you give? Has anyone got any ideas what sorts of information you would give about the diet? Yeah? Okay.
Another issue is counting the calories.
Sure.
Issue.
Yeah.
Usually avoid sugary diet.
Sure.
And so on.
Yep. And did you have any other or same? Yeah. 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 Perfect. So that sounds fairly consistent. We don't, in our centre, we don't give a prescriptive diet, so we don't tell people exactly how much carbohydrate to eat with gestational diabetes. It's different from type 1 or type 2. We don't do that. We don't tell them which foods to eat either, but we give them broad instructions about how to modify their diet to be a bit more for it to be easier to manage their gestational diabetes. So one of the big things that we know is that breakfast is particularly poorly tolerated. So if you work with pregnant women, you see that as soon as they eat breakfast, their sugar's just high. And often that's the reason most women end up needing insulin or treatment other than diet, is that breakfast reading. So one of the things you can do there is, say, have a very small amount of carbohydrate, so one slice of bread or one small cracker or a small amount of rice with lots of other things, and then have a split breakfast, so an hour, 2 hours later, have some more food. And that's one of the things that we fairly routinely advise women to do once they're diagnosed with GDM, because it keeps their sugars a little bit more stable. Okay. What about testing regime? How many times would you get them to test, and when? Before meals? Any other opinions? Everyone agrees then, before meals? No? After, 1 hour, 2 hours, 3 hours? 2 hours, yeah. Does everybody agree with that? So I think this, again, is something that differs quite a lot for in different centres and with different practitioners. What we do, and I can explain why, is that we get them to test 4 times per day. They test fasting reading before breakfast, and then 1 hour after each of breakfast, lunch and dinner. And the reason for that is, for most meals, the peak glucose concentration is 1 hour after. So there are different cut-off criteria. If you really want to stick to 2 hours, then it's important that you use different target glucose values compared to if you're using the 1 hour readings. But we tend to do 1 hour. And it also gives women a chance to, if they want to split their meals like that, they can eat a small meal, test 1 hour after, eat some more, test 1 hour after. It's a little bit easier to manage for most women than the 2 hours after. Yeah? We don't test before as well, so that's often a little bit controversial. Some people say we should be testing before, particularly if these women are on insulin, but we don't, because we only adjust the insulin doses based on the postprandial readings. We wouldn't do anything with the pre-meal readings, so we don't test it then. And often, because diabetes is new for these women, it's quite a big deal already to be testing 3 or 4 times a day. So to get them to test 7 times a day, like the women with pre-existing diabetes, is quite a big ask. And most of the time it's not needed, so it doesn't seem fair, especially if we're not going to use that information. Okay. So these are the readings from when she first had her education. She's had diet and lifestyle advice, and she's testing 4 times a day. I'm sorry, though, that's hard if you don't have the proper conversions. So these readings are all between 100 and 110 in the fasting category. All of the readings are under about 170, so that most of the readings after breakfast, lunch and dinner are in target, but particularly the one after breakfast is a little bit high. On maybe every second day is above the target. Okay, which is, the target is 140 1 hour after, yeah? So these ones are, some of them are slightly above, some of them slightly below 140, and the fasting is about 100, 110. Okay? Is that enough information for you to make a decision about what to do? Yeah. Yeah. So 140 is the cutoff. Yeah. Pardon? Yeah, they're higher. Yeah, so they're a little bit too high. Yeah, exactly. So some of the time they're a bit too high. And the same after breakfast, but lunch and dinner are okay for now. All right, so what would you do at this point? What, metformin did you say? Yeah. Or basal insulin, yeah. So I was just having a chat with this gentleman here and saying that basal insulin seems to be the way to go. Is that right for most of you? Would that be your first step? Or metformin? Metformin. Okay, hands up for metformin. Right? And what dose would you use? What dose? Yeah. Start 500. Start low, gradually increase. Great. Yeah. Those of you who'd start on insulin, what would you do? What sort of insulin would you choose? 10 units. 10 units of Levemir. Breakfast or like in morning or at night? Night. Fine. Okay. Yeah. Anybody have any differing opinions about what you would do? Maybe mixed hard. Pardon? 6 units, and then you might increase, yeah. But still the Levemir? Yep. Yep.
Actually, for starting with metformin or basal aspirin,
Yeah.
should we wait for 1 to 2 weeks?
So it's a common thing is how long should we wait before we start to see whether the lifestyle things will work, right? Our general approach is we give the education about lifestyle as soon as possible, and then they come back 1 week afterwards. If they come back and they say, I'm making these changes step by step, I'm still learning, things are getting better, and you can see things are getting better, their sugar's coming down, then we give them a bit more time and they might get there. If they say, I was eating pretty well beforehand, I didn't really need to make any changes, I'm doing everything that I can, and their sugars are still high, then we just start treatment. Because in pregnancy, you have such a finite time. You can't waste a couple of weeks. It's different, right, from outside of pregnancy. You don't want to waste another 2 weeks till they come back, or another 2 weeks after that, wait and see if this works. No. So you've got to be quite quick, saying, is that working? No. Okay, what's the next thing? So, Yeah. Yeah, 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 yeah. So we use a mix of the extended release or the normal routine metformin. The metformin issue, I think, is tricky. Some people feel very comfortable giving it out completely to everybody. Some people are very nervous about it because it crosses the placenta. What we do is have quite an honest discussion with the woman before we put her on it. So we say the safest option we know does not cross the placenta is insulin. That's, if you want to be 100% sure, then insulin is what you should take. But that's injections, and there is this option of a tablet. We know that the tablet does cross the placenta. We're not sure really what that does to the baby. There's no indication that it causes any problem at the moment, and many women have used it for many years. But it does cross, and that's why it's not routinely recommended in the guidelines internationally. And then each woman will make her own decision. Some women say, that's fine, that sounds good, I'll take the tablet, and some people say, actually, I'd rather do an injection. And so each person makes their own decision. That's what we do at our unit, and that means that some women, but probably fewer than other centres, are on metformin. And then we would do the same. We start at 500, start at night. If you're doing extended release, then just stay at night, but just increase gradually from 500, 1,000, 1,500, 2,000, and then usually a maximum of 2,000 or 2,500. If you're using the daytime ones, then we usually start at night as well, so say with dinner, and then with breakfast, 500, 500, and then gradually increase so that it's spread across the day. In this particular case, so this idea of giving just basal insulin is something that I wasn't very familiar with until I came here. So what we normally do is look at the problem area, look at where the sugars are high, and then give insulin according to that. So in this, yeah. Yeah, exactly. So that's what we would do. So what our approach to this would be, we would maybe have a discussion about metformin, but we would know that that would take at least a few weeks to work. And then if we were going to start insulin, we would probably start Levemir maybe, or Insulatard at night to bring down the fasting reading. And additionally, we would give a small bolus of a rapid-acting insulin analogue with breakfast, because that's the problem area. So if it was only high fastings, then we would give just the basal. But if it was only high post-meal, then we would just give short-acting insulin with the meal. Yep, yeah. Of mixed insulin? Pre-mixed insulin, yeah. So I had this question before as well, and we don't really use it, with a very, very small exception. Every so often there's somebody who refuses insulin in any other form, in which case that's better than no insulin. But I'll explain the reason that we don't give it routinely, we don't recommend it, is because the ratio of basal to bolus is fixed. And that is not true in pregnancy, right? So early in pregnancy, there's quite high insulin sensitivity, and the amount of insulin needed to cover a meal is relatively low. So the bolus amount is small compared to the basal, often 30 to 50%. Around the middle of pregnancy, it becomes about 50-50, and then by the end of pregnancy, it's the bolus that increases massively. So you end up with 70% bolus, 30% basal, or thereabouts. And because that ratio is changing across the course of the pregnancy, the basal insulin almost always stays relatively stable. If you look at physiological studies, basal requirements don't change. What changes is the carbohydrate metabolism and insulin. So you need to increase the boluses, but not the basal, which you can't do with mixed insulin. Does that make sense? So that's our kind of explanation. There are very occasionally women who we do use mixed insulin, but most of the time we just use basal bolus. But particularly with GDM, it doesn't mean that they need necessarily 4 injections a day. It might just be that they have one short-acting injection at breakfast, and that's it. That's the only insulin they're on, and that's quite common. In terms of dosing, people have different rules about how they start. We do it pretty simple so that everybody does the same. We usually start with 2 to 4 units of rapid-acting insulin with the meal when we're starting, and about 4 units of overnight of Levemir or Insulatard. So they're quite low doses, but because these women have not been on insulin, and often their sugars are relatively good actually, they're just abnormal for pregnancy, but they're not very high. So we start slow and then just titrate every couple of days as we need to. Yeah? Does anybody have any questions or comments on any of that? Any disagreements? You're allowed to. I know that it's not normal here, apparently. It's normal to just give the basal, is that right? Yeah? No? Okay. So we'll move on. So yeah, we've talked about which type of treatment we would offer, diet and lifestyle first, then think about metformin, and then maybe insulin. Fine. Does anybody give insulin pumps for women with gestational diabetes? Or just injections? Injections. Yeah, fine. Same with us. But in some parts of the world, they do give insulin pumps. So particularly in Southeast Asia, a lot of people with gestational diabetes end up with insulin pumps. But it's not really necessary, because we can see that from our data, if you manage well, if you're proactive managing gestational diabetes with injections and with metformin, then the complication rate is the same as the general obstetric population. So there's no need to spend more money, more time and effort doing very strict carbohydrate counting and insulin pumps. Fine. So this woman was started on insulin at 30 weeks gestation. She had Insulatard or isophane insulin, 4 units at night, and then 2 units with breakfast, so in that same way that we described. And over the coming weeks, the next few weeks, the breakfast insulin dose started to increase, so she was on 8 units with breakfast in the morning, okay? But she was struggling because she was having hypoglycemia before lunch. So she was still going high, but she was having low blood sugars before lunch. What could we do about that? Any ideas? You could, yeah, so one option would be to potentially increase or even just keep it the same and give a snack mid-morning. Yeah, that's a pretty common advice, I think, isn't it? Give some extra food mid-morning. Has anybody got any other ideas? Does anyone remember from anything I said this morning? Yeah, exactly. So shift the bolus before breakfast. So what we often do is, as the pregnancy progresses, we increase the time between when we give the injection or the bolus and the meal. So earlier on, particularly if we're using NovaRapid, insulin aspart and Lispro, we give it about 15 to 20 minutes before the meal at the start of pregnancy, but it becomes more sluggish as the pregnancy progresses. So yeah, so we go up to 45 minutes or 1 hour. But you don't do it suddenly. People are worried that it will cause a low blood sugar. You don't do it suddenly. So you say 15 minutes, okay, why don't we increase 20 minutes, 25 minutes, half an hour, 40 minutes, 45 minutes, an hour, whatever. Okay? And actually it's one of the best ways to address this problem. And because particularly we're worried about women gaining too much weight in pregnancy, so we don't really want to tell them to keep eating just to prevent hypos, yeah? So particularly that mid-morning, if they're hungry anyway, if they want to eat, then sure, that's a perfectly good way to do it. But we don't want people having to eat to counteract their insulin when you can fix it with timing a lot of the time. Yeah? Has anybody tried that themselves? Does anyone do that already? Change the bolus time? Yeah? Yeah. Do you think it's useful? Yeah. Good. Yeah. I'd really encourage you to give it a try if you haven't before, because a lot of people think they're skeptical or they think their patients won't like it or whatever, but actually once patients see that it works and they can eat a bit more even sometimes, then usually they come around to it. And you can fit it in with your lifestyle relatively easily. So some people inject when they wake up and then wait, have a shower, do everything else and then eat for breakfast. Yeah, exactly. Fine. So this woman progressed well through the rest of her pregnancy, and she had her last visit with us at 36 weeks gestation. So in our country, she's advised to have induction of labour at 38 weeks because she's on insulin. And so we have our last appointment with her at 36 weeks. What sorts of things do you think might be useful to discuss at this point with the patient? Mode of delivery, yep. So the obstetricians discuss that often even a little bit earlier, but definitely at 36 weeks you should have an understanding of whether it's going to be induction or cesarean section or what. What other things? Yeah. Yeah, perfect. Yeah, so that's one of the ones that I think a lot of people forget, is a discussion about what happens after delivery. So the way that we kind of go about it is have a checklist at the 36-week visit. This is one of the most important visits. We talk about the mode of delivery, how a woman is going to manage her glucose in labour and delivery around that time. So our routine advice is that they continue on their treatment right up until the baby is born. If they're going in for a cesarean section, they don't need to take their basal insulin. If they have daytime basal, they don't need to take it on that morning. Have an injection if you're eating, not if you're not eating. And if you're not eating, then don't take metformin either. But as soon as the baby is born, they can stop their testing, stop their insulin, and then 6 weeks afterwards or thereabouts, they have a repeat oral glucose tolerance test. Is that the same here? Yeah? Similar? Fine. The other things that we talk about, as you say, are, so we talk about that test 6 weeks afterwards, but also have quite a serious discussion about the risk of type 2 diabetes down the track. So we say this is a warning sign, you're at high risk of type 2 diabetes, but there are some things that you can do to modify that risk, to reduce that risk. So those things include diet and lifestyle, similar to what they've done in pregnancy, but a less strict version usually, hopefully staying very active. Sometimes they can take metformin if they think that if they're at particularly high risk and if their doctor's okay with that. They can breastfeed, which is incredibly important. So at least in our centre, most women know that breastfeeding is helpful for the baby and for immunity. Some women know that it helps them lose weight after having their baby, but not many women know how important it is in terms of their own metabolic health. So we have that discussion as well and say that it halves their risk. If they can breastfeed for 3 months, it halves their risk of type 2 diabetes. So it's really important, and we try and offer them as much support as we possibly can so that they're able to breastfeed if they want to. Yeah. We also then talk about contraception or pregnancy planning. So after the 6-week follow-up visit, assuming their glucose tolerance test is normal, then we advise them to have a repeat glucose screen every year, and we often get them to time that with their child's birthday so that they remember to go to the doctor and have a check. And at different centres that will be either with a glucose tolerance test or with an HbA1c or with a fasting glucose, and there's not much evidence about which one's the best. But they should also have a test before they plan to get pregnant again. And if they unexpectedly find themselves pregnant, then they should tell somebody very quickly to try and get tested as soon as possible to see if they have diabetes again, because about 40% of them will have it again. Contraception, so that they can plan their pregnancies a bit more carefully and try and make sure that they're linked in with that and know that breastfeeding is not a safe, effective contraceptive method. So if they really want to prevent pregnancy, then they should be using a safe, effective form of contraception. Okay? Any questions on any of that? Yeah. Pardon, sorry, I missed the... How many calories? Yeah, so we don't give them a daily calorie limit at all. We don't talk about calories or about carbohydrates. We just talk about the types of foods that they eat. I think if we calculated it, it would be somewhere between 1,800 and 2,000 calories a day, but we don't count. So some women will have much more and some much less. It's a little bit difficult because obviously the women vary quite a lot in terms of their weight and in terms of what their diet was like beforehand. And I think there's also a difference in terms of the pathophysiology. So we have some women who are very obese and then have only mild glycemic disturbance, and other women who are quite thin but have really high blood sugars. And I think that's clear that there's something a bit different in those two scenarios. So having one very strict diet might not be the best option, and instead trying to tailor it to the individual woman. Some people are also very concerned about starvation ketones or having any urinary ketones at all. Our approach, and I think it's difficult because there's this theoretical understanding that high blood ketones can have a problem for the baby's brain, can cause neurodevelopmental problems or brain injury. The evidence for that is quite poor and quite mixed, and actually it looks like women who stay weight neutral or even lose a little bit of weight have perfectly healthy babies. So our general approach to that is to say, eat a healthy diet. If you lose weight, you will or don't gain weight according to your pregnancy, then you will obviously have some level of ketones, right? Because that's how the biology works. You will have some ketones from burning fat. If that is because you're restricting your diet so much to keep your blood sugars perfect and you're not eating any carbohydrate, then that's a problem. That's not a healthy thing to do for you or for your baby. If you're doing that by just cutting out Coca-Cola and chocolate bars, but you're still eating a perfectly healthy diet, then that's probably okay. So if someone comes to our clinic and is not gaining much weight, that doesn't mean we necessarily worry and change something dramatic, but what we do with everyone who doesn't gain weight or who loses weight after a period of time is have a discussion with them and see what they're doing, see how they feel about their diabetes. If they are having to work really hard and be hungry all the time in order to keep their glucose levels good, then we would say maybe it's time to start metformin or insulin so that you can eat a bit more because it's important for your baby to get good nutrition. If they say, oh, it's fine, I'm eating plenty of food, the same as you, but I just cut out all of the rubbish that I was eating before, then we let it go. Does that make sense? So it's a bit variable depending on the patient. Yeah.
Newly diagnosed diabetic since the first trimester, can we consider here GDM?
Yeah, good.
The first month,
Yeah.
was the first time.
Yeah. Did everybody hear that? So it was somebody who has newly diagnosed diabetes in the first trimester, very early pregnancy. Is that still GDM? And I think according to the global definitions, the WHO definitions, yes, any diabetes first diagnosed in pregnancy is gestational diabetes. But I think it's quite clear that that's something different, right? And that type 1 diabetes can be diagnosed obviously in pregnancy too. So it's something that needs to be in the back of your head, and you think, you need to be thinking of that. But in reality, for most of the time, you can treat the patients almost the same because you're managing their blood sugar levels. If someone has type 1 diabetes and you're giving them a bit of dietary advice and their sugar's still really high, then you would treat them just like you would any other person with gestational diabetes who had very high sugars. You would start them on insulin, right? If you had someone with run-of-the-mill gestational diabetes, which we do see occasionally actually very early in first trimester, but it goes away after pregnancy, it is gestational diabetes, but some sort of more severe form, then you do the same thing. If their sugars are high, after you've tried things, you give them insulin. So it doesn't necessarily matter so much what you call it in pregnancy. What's important is if you are worried that it might be type 1 or type 2 diabetes that's come on very early or that was there before they were pregnant and you just didn't know, then that you follow them up very carefully after delivery. Those might be the patients where you don't say stop everything after you've had your baby, and instead you keep blood sugar testing and decide if they need to continue on insulin at that point.
Because the target blood sugar
Yeah.
is different. Whether it is gestational or it is diabetes associated with.
Okay, they don't for us. We use the same targets for gestational diabetes, or yeah. So for us it doesn't. If you use different targets, then yeah, you might need to think about it. And also if you have, so at some centres I know they have different scanning regimens. So if you have pre-existing diabetes, you might get some extra scans or tests and things like that. So I think you've got to treat each case individually. These cases are rare, and often you have an understanding of if this is type 1 diabetes or MODY or something that you think is abnormal, it's not normal gestational diabetes, then you might treat that differently, but it will depend on the individual centre. And for us, because we use the same targets, it actually doesn't really change that much. We just keep a very close eye on them after delivery, and that's when we step and might change things, do extra investigations and things. The other thing is there does seem to be, which is not very well described because often just the way that studies are conducted, they're after 12 weeks. So they're once people know that they're pregnant, they've had their dating scan, and then we follow their glucose levels up after that. But there is a period before that of insulin resistance associated with hyperglycemia. So we know in women who are at risk of GDM or who later go on to develop GDM, some of them will test at home, they've had gestational diabetes before, some of them have somebody else's meter at home they can test, and a number of them will have a period where they have quite high blood sugars, around 8 weeks gestation, and then it goes back again to normal, and it doesn't look like any problem, and then they go high again later. So, I mean, the message is the same, right? You treat the numbers that you've got in front of you at the time, and you put them on insulin if you think they need it, you take them off it again if you don't think they need it, and just wait and see, and then after delivery, the picture should become a bit clearer. Yeah?
Fasting, fasting blood sugar in this case is 95.
So I'm bad at the conversion. It's 5.3 for us. I just don't know what the equivalent is. Does anybody know? Yeah. Yeah, I don't know the milligrams. Yeah, 95. Yeah, that's our cutoff. Yeah, same. Yeah. Okay. Yeah, 95.4. So same that what you use, I think. Is that right? Great. Fine. So she had induction of labour and vaginal delivery at 38 plus 2 weeks, and she had a healthy baby girl, 3.9 kilograms, so still big, but not quite as big as the previous one. So, and we've talked a little bit already about what now, haven't we, in terms of reducing her risk of type 2 diabetes, the follow-up and those sorts of things. Fine. Oops. So this is the second case study. This is somebody with type 1 diabetes. So she has type 1 diabetes since 1983. She did the DAPHNE course, structured education course about carbohydrate counting and dose adjusting insulin in 2010. And she was referred to our clinic, pre-pregnancy clinic, because she wanted to get pregnant in May 2013. She'd had a previous stillbirth, some mild retinopathy and gastroparesis as well. And she had an HbA1c of 10.3%. So, what do we think about this? She's not pregnant. She's come to our pre-pregnancy counselling service. Yes. Yep. Yep, exactly. So, does everyone agree with that? Yeah. Try and control the diabetes first, yeah. Oh, you agree. Perfect. Good. We're all on the same page. Pardon? Okay. Yeah, so that's exactly what we would say. We would put her, if she's happy to go on contraception until she controls her blood glucose a bit better, controls the diabetes, but definitely try and avoid pregnancy until this situation is a little bit better. What other things would you talk about in this case? Ophthalmologist, yep, make sure she's getting her eye screening. Yeah, exactly. So what we would generally do is say stop all of the harmful medications, so you can stop ACE inhibitors, stop statins, talk about generally having diabetes in pregnancy, the fact the large majority of women have healthy pregnancies, but the way that we do that is trying to make sure that the diabetes is as well controlled as possible. And then we would normally set an HbA1c target and make sure, if we can, that she's on folic acid before she stops contraception. If she doesn't want to go on contraception at all, then make sure she's on folic acid, and we would still advise trying to not get pregnant until the HbA1c is better. Yeah? What do we think is a good target HbA1c for her? 6.5, yeah. So ideally 6.5, absolutely. How likely do you think it is that this woman is going to wait until she has an HbA1c of 6.5, given it's 10.3 now? Yeah. You think she can do it in 3 months? No, she can't, right? It's unrealistic. Sometimes women are happy to wait a year. They'll say, I'll put in a lot of effort for a year. But even in a year, maybe it will be easier if she's not taking her injections, not worried about it now, and she all of a sudden starts to worry. Maybe it will come down. But it's really difficult to, if your HbA1c is 10.3, to get it to 6.5 often seems like an unrealistic goal. So we often find that if there's these women with really poorly controlled diabetes, sometimes even higher, 13% or whatever, and you say you need to get it to 6.5 before we'll let you get pregnant, they just don't come back, right? They get pregnant themselves, don't come back. So it's about having a discussion, trying to make sure that it's realistic. The new guidelines say aim as close as possible to 6.5, but it doesn't necessarily have to be 6.5 before you stop it. So with someone like this, we would often say, why don't we aim for 7? Yeah, and let's do, or say, you give it your best go, let's get to 6.5. They come back in 3 or 6 months' time and they got to 7, and you say, you know what, I think that's okay. Let's say, fine, you can try. So it's about making sure that you have a balance, and so that we can keep women engaged and still wanting to come, even if you're giving them some messages about waiting, and make sure that they trust you and that they think it's realistic and possible. Fine. So we did all of that, and she got pregnant slightly before we anticipated, which happens a lot of the time. So we weren't quite at the level where we'd said go and get pregnant, but she did. So her HbA1c, when she first told us that she was pregnant, was 7.6%, so much better, significantly better than 10.3, but still a bit high. Those were her doses. She was on Humalog, Lispro, and Levemir. At 8 weeks gestation, she had to reduce the Levemir and the ratios because she was having a lot of hypos, which is quite common, obviously, in the early part of pregnancy. And she had been injecting after her meal, after eating, so she changed that. She was injecting before. We gave her some dietary advice, talked about the suggested distribution of carbohydrates, so 30 grams, 50 grams. And she was having the dawn phenomenon, so she was going to bed with a good blood glucose, having good blood glucose, but then it drifted up again before she woke up. So to combat that, she was waking up every night to give an injection at 3 a.m. and try and wake up in target. And at this point, we decided that it might be good for her to go on to an insulin pump. What does everyone think about that decision? Yeah? Do you have access to insulin pumps? Could you do that? Yeah.
What do you mean by homolog to?
So these are the ratios. So 2 units to 1 unit of carbohydrate, which is 10 grams, or 1.5 units of insulin. So at breakfast, 2 units of insulin to 10 grams of carbohydrate, or 1 carbohydrate portion. At lunchtime, 1.5 to 1, 1.5 units to 10 grams of carbohydrate. And at dinner time, the same, 1.5 units to 10 grams of carbohydrate. Sorry, 7 in the morning, 7 units, 12.5 units at night. Yeah, exactly, divided dose. Sorry, I should clarify. This is how we routinely present it in the UK, so I didn't realise that that's different for you. Okay. What does everyone think about an insulin pump? Excellent decision. Great, I'm glad you support it. Everyone agree? Do you all have access to insulin pumps? Mm-hmm. Yep. Yeah. Yes. 8 weeks gestation. So she was 8 weeks pregnant at that time. 8 weeks, yeah. So very early pregnancy. Yeah, grams. So she had 30 grams for breakfast, 30 grams as like a mid-morning snack, 50 for lunch and 50 for dinner. Yeah. Mm-hmm. Yeah, so some mixed opinions, I guess, on the pump. So I'll talk a little bit about insulin pumps. Are you, as a group, kind of confident using insulin pumps in general? Yeah? Do you use them routinely? No. Don't use them at all. You don't use pumps at all. Pardon?
No, infusion syringe.
Right. Okay. Okay. Okay.
Not more reduction in
Yeah, exactly. So there are a couple of different ways to deal with it. You can continue to reduce the levomir. Yeah, you can, and you can definitely combat it. In fact, on the concept trial that I talked about this morning, that's published in the Lancet, the CGM trial, it showed that there was no difference in terms of the pump and the MDI injections. So you do not have to transit her. I'm not saying this is the only right answer to give her, to put her onto a pump. In our unit, we're very used to technology, so everybody is knows how to do it. We have access to it. So that's our go-to answer. It's one way to solve the problem, and I'll talk about some of the reasons that that might be useful, but it's definitely not the only way to solve it. And particularly with someone who's motivated and staff who know what they're doing, you can get almost equivalent results with injections. The convenience is different. So I think you could reduce the levomir here. You could time her meals a bit differently maybe. You could change the amount of carbohydrate and try and reduce the hypos. The 3 a.m. injection is difficult to avoid. That's annoying if you have to wake up.
6 injections is extremely difficult.
Yeah.
Plus, you have another more injections for checking.
Exactly. 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 So that's the main probably advantage of a pump. And I'll talk about some of the other things that a pump can be useful to if you've got access to them. But I don't think there's anything wrong with injecting in the meantime. Yeah. Other than, as you say, it's quite a burden for the women. So this was the trace after she was started on a pump, and actually you can get that sort of control very quickly with appropriate staff, with high number of visits and high contact with the patient to make sure that they're transitioned smoothly. Yeah. 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 Yeah, exactly. Yeah, of course, yeah. So that's what we use when we don't have a pump or we don't have continuous glucose monitoring. Yeah, then we do use a 7-point profile. And there's not, I mean, until recently there was no evidence that CGM was any better than a 7-point profile. You can get most information, and some women are testing even more than that. So this woman here was very motivated. She didn't have CGM, but she was testing. You can see it, I don't know if you can see just up in the corner, she was testing 13 times a day, which not everybody is willing to do, but it does help you control things, obviously. And at 10, if you do 10 tests a day, that's just as much information as you would get from CGM, roughly. Right. So, are you familiar with looking at these downloads or not? No. Has anybody seen this before or something like this before? No. Okay. So this here, these are blood glucose levels. The dots is each time someone does a finger prick test, it shows. The shaded area is the target range. And this is the sort of the green here with the lines are the insulin boluses. And this is the sort of download you would get from an insulin pump. So when you connect it to the computer, you get this kind of information. And each square here is 1 day. So what you can see is that this person is giving many boluses during the day. Those green spikes are the boluses. So they're able to give boluses all the time. They're also testing all of the time, really frequently throughout the day, every day. Are there any patterns that you can see looking at this about when you might or how you might advise someone to change their doses? No? I might come over and point on the actual screen. Is that okay? So, if you see here, there are some readings here that go above target. That's a peak after lunch, yeah? And you can see that it's a bit hard to see up close, but I think it happens a few days in a row, yeah? It happens. Yeah, can you hear me? I don't know. Can you hear me? Yeah. So you can see it happens a few times in a row after lunch, yeah? And there are other similar patterns, it's a bit hard to see, but basically these postprandial peaks. And so that means that you can then, as the same as you would with injections, give advice about the dosing for the boluses. Yeah? So we would reduce the ratio, which means that you give more insulin for the amount of carbohydrate and try and adjust for that after lunch peak. Yeah. The good thing also about pumps, if you can get them, is that they can be uploaded remotely. So we have a service where patients can do that at home, and a diabetes nurse will look at the results on the computer in our clinic, and then they can email instructions to the patient, so they can do that in between appointments. So for us, routinely, this sort of patient would be seen every 1 to 2 weeks throughout their pregnancy, but in between times they would upload maybe twice a week, and the nurse would give them advice in between. You can also then use this to say, you're having a peak every lunchtime, maybe not every lunchtime, do you do something differently on those days? And those sorts of normal discussions that you have, right, anytime. Perfect. I'll come back over to the... Sorry. Fine. Are there any questions about any of that? No? I'm just going to see that. Fine. So in terms of the transition to pump, again, this might not be so relevant if you're not transitioning all the time, but similar to what Pratik was talking about this morning, Dr. Chowdhury, we start with a flat basal rate across the course of the day because we're not sure what their basal requirements will be. Other than the fact this woman needed a little bit more insulin because of the dawn phenomenon, a little bit more in those early hours of the morning. We also talk about the timing of the insulin, so the same rules apply whether you're on a pump or injection, about giving the injection before your meal and extending that time across the course of the pregnancy, and the choice of breakfast food as well. So particularly the breakfast time is often really important, and so making sure that people have low carbohydrate breakfast is one of the best things that you can do. This woman then had an emergency caesarean section at 36 weeks gestation, and she had a big baby, LGA baby, who had neonatal hypoglycemia and went to the neonatal intensive care, which is pretty common. Even though she had pretty good control, it wasn't amazing, but she got pregnant unexpectedly. So all in all, it's a pretty good outcome. In her third pregnancy, so you'll remember the first pregnancy was a stillbirth, second pregnancy was this one we've just talked about, and this is the third pregnancy. So in this time, she was more confident using her insulin pump. She knew what she was doing before she got pregnant. And so this is the pump reading right at the start of her third pregnancy. And you can see that the majority of readings are in target. So it will never be completely perfect, but this is pretty close. So in her third pregnancy, it was much calmer. She knew exactly what she was doing. And she delivered via an elective caesarean section at 37 weeks. The baby did need a little bit of extra feeding, but no admission to the neonatal intensive care unit. So what that, I guess, demonstrates is that with extra planning, trying to do things as early as possible before the pregnancy, you can improve outcomes. Yeah. So I'll talk just a little bit about the sort of discussion points that we have when managing women with diabetes in pregnancy and what we look at in each visit. So the main things that we look at are the average blood glucose, mean blood glucose, and we also look at the standard deviation. So you can do that on a pump or a CGM, but you can also do that on most of the meters. It will calculate a mean. Do any of you do that routinely? Look at the average? No. So, pardon? Yeah. Yeah, exactly. Yeah. Do you look at that and make decisions based on that, or no? Your average blood glucose monitor will calculate an average for you. And you're aiming for, in pregnancy, for that mean blood glucose to be as close as possible to 6. So if it's much higher than 6, then you know that something's not right. So you've got to look at where the problem is and you can make adjustments, but it's a good ballpark to say, is this woman going okay or not? The problem is HbA1c is not very effective in pregnancy. It's not very accurate. So the relationship between glycemic control and HbA1c is different for different women in pregnancy, and it changes more rapidly than it does outside of pregnancy as well. So we do collect HbA1c once per trimester, but we don't really use it in terms of making any massive decisions, or even in terms of like congratulating or motivating a patient. We use the mean blood glucose instead, the average, and you can do that every week, and women can do that at home and check it themselves and know that they're aiming for close to 6, obviously without hypos. Yep. The standard deviation is also good because it gives us an indication of the variability, so whether the glucose is fluctuating all over the place and it's extremely different on different days, or whether it's fairly consistent. We talk about the frequency of testing. So at a minimum, women with pre-existing insulin-treated diabetes should be doing 7 tests a day, but often they need to do even more than that. So what we normally say is 7 as the baseline, but also any time that you think you need it. So once women get to know and manage their own diabetes, they know. For instance, sometimes overnight testing, sometimes if they're doing sports around those sorts of things, or if their sugar's high, then they'll start doing more testing, or if their sugar's low. We talk about the total daily dose of insulin. So as I was answering the question about mixed insulin before, we know that the basal stays relatively stable across the course of a pregnancy, but the bolus requirements increase quite substantially. And so giving women an idea of that, and that their insulin doses may double or even triple by the end of pregnancy, but most of that will come from bolus insulin, is useful, because otherwise women think that they're abnormal. They're not sure why their sugars their insulin requirement is going up so high, and they're having to give these massive injections of 40 units at a time, and that can be quite scary. They're worried about having hypos and things. So explaining that that's normal and that's what's to be expected right from the start of pregnancy can often help women adjust to that. Keeping an eye on the basal bolus split yourself at different appointments is useful as well. So if we see that we are increasing the basal a lot across the course of the pregnancy, we think maybe we're doing something wrong here. It seems like they need more basal, but is this really accurate? Maybe we should be giving them more bolus and less basal. And often even the basal requirement comes down across the course of the pregnancy because you have to reduce it in order to accommodate the really high boluses without hypos. We talk about hypos quite a lot and when they are likely to happen. So we know that they happen particularly in that first part of pregnancy between about 8 and 20 weeks gestation, and they can have different symptoms from what they have outside of pregnancy, and often no symptoms at all. We make sure that every woman knows how to treat their hypos, that they all have glucagon at home, and that their partners know how to give it, and that they're confident doing that. We also set up a range of things. So the number one cause of maternal death in women with diabetes is low blood sugars. And so there are a range of things that they can do to protect themselves. If they're having naps during the day, then we make sure that they set alarms for every half an hour and check their sugar. Make sure that somebody knows that they're having a nap so that they can come and check on them if they don't wake up, and those sorts of things. Because the majority of the women who die from low blood sugar, it's while they're napping in the middle of the day. It's not overnight. It's not, a massive insulin overdose. It's having a nap in the middle of the day. Often when nobody else is at home. So making sure that you put in safeguards to make sure that that's a safe thing to do is something that we talk about routinely with every woman who becomes pregnant. Ketone testing as well. Does everybody recommend blood ketone testing or urine ketone testing? Either?
Checking acetone.
Yeah.
Not routinely checking
No.
ketones and blood.
Yeah.
Not available.
Okay. Do women have access to urine sticks or, yeah. Okay. Ketone urine stick. Yeah. They are not reliable, exactly, but they're better than nothing. Yes, exactly. So that's the thing. So we don't recommend routine testing for ketones at all. So some, I know in Russia, I gave a similar talk and they said every day they get their women with type 1 every day to do a ketone test. I don't know why. We don't do that. So, but what we do say is if the glucose is above 10 for more than 2 hours, then they should do a ketone test. So ideally that is with a blood ketone meter, but if you don't have access to that, then a urine is better than nothing. And actually, having 4+ ketones on a urine stick is a sign that something's not right? And if you combine that 4+ ketones with a high blood sugar, then that person needs to get some insulin and go to hospital potentially. So making sure that women have instructions about how to manage high blood sugars and making sure that they're aware of the higher risk of DKA even at lower blood sugars in pregnancy is important, so that they go to hospital if they need to. If they're on a pump, we talk about pump failures, pump issues, and what to do. Make sure that they have injections as well in case any of the technology fails. We're also very lucky in our centre. We have a 24-hour phone number that they can call. So it's staffed by a diabetes specialist nurse, and 24 hours a day they can phone and ask for advice anytime, which is pretty amazing. And it means that a lot of women don't have to go to hospital, because if their sugar's a bit high and they're not really sure what to do, they can ring, get advice, and often, even if they have to call many times overnight, they can avoid going to hospital. So again, if that's an opportunity at your centre, then it's worth investigating and seeing if it's possible. Even though it seems like an expensive service or something that you might not be able to get, it saves quite a lot of money in terms of admissions, so it's worth having a discussion in your departments if that's something that you can do. This is just about pumps in pregnancy, less relevant if you're not, but maybe if you're not able to get them, but maybe in the future. Some of the things that we like about them are that you can meet the basal requirements more accurately. You get improved insulin delivery and absorption that is a bit more close to normal physiology. You can use the bolus calculators on an insulin pump and make very small adjustments to insulin doses, which means that we're able to get very tight blood glucose control during pregnancy, which isn't always possible with injections. And we get those pump downloads, which are actually very useful in the clinic to be able to look and see the patterns over time. It's also possible to reduce the incidence of hypoglycemia. So the pumps have facilities to use temporary basal rates. So if, for instance, you go and do some exercise, you can reduce the basal insulin by 20% or 30% and avoid hypoglycemia, which is obviously impossible with injections. Once you've given it, it's all in there. So you'll have to eat to compensate, whereas here you can actually take out basal insulin, which is a benefit. In terms of the best time to initiate pump therapy, if you're going to, ideally we would do that before pregnancy, so 6 to 12 months. We do it very quickly, more quickly than we would outside of pregnancy. You do it just in 1 or 2 days, transition them to the pump, and then have very close contact with them for the next few days afterwards. If you are transitioning them to a pump, particularly if it's new for you, then we have a fairly standard way of doing that. We take the total daily dose on injections, reduce it by 30% because pump therapy is more efficient, and then split it 50-50 into basal and bolus. We aim for the targets slightly higher, so I guess that's about 140, 150 for the first little while, so that they don't have too much hypoglycemia for the first 24 hours, and then we reduce it to the normal pregnancy targets after that. Yeah. In terms of labour and delivery, what's your kind of standard approach? Do women here go on IV insulin, intravenous insulin during labour and delivery, or injections? What do you normally do? Pardon? Injections. So they continue on their normal therapy in labour? Yeah? If someone has type 1 diabetes and they go into labour, would you put them on IV insulin, or they would just continue on their normal injections? Normal injection. Yeah. Yeah. Okay, so that's uncommon, I think. Like in the UK, most women go onto IV insulin, but it's not actually as good as we wish it would be. The sliding scale is not very effective. So where we try and keep them on injections as well, as much as we can. But if their sugar's high or low, then we need to do something about that. If they're on pump therapy, we try and continue them on insulin pump therapy for that as well. We know that these devices and CGM are all safe in theatre, They're all safe during labour and delivery. But immediately after the baby is born, we need to reduce the doses quite substantially. So we do that either on the pump or via injections, depending. And our standard advice is that the first meal after delivery, they should not have any bolus insulin at all, because they're so at risk of hypos, so they can just eat, no insulin. We then usually give about 0.5 units per hour of a basal rate, or half of what they were on before. And then their ratios, carbohydrate ratios, of 1 to 12 to 15 grams of carbohydrate. Does that seem roughly similar to what you would advise? Yeah, a few nods. Okay, fine. So that's they're the main case studies that I wanted to talk about. I've got a few other bits, but I wonder if it's better if we can just, we're almost out of time, it's 7:30 now, so if anyone's got any questions, maybe it's best if we do that. Any questions or comments, and then we can finish?
2 slides before this, I asked about why you are giving saline for the baby.
Yeah, saline, yeah. So the kind of traditional thinking is that if you put someone on an insulin pump, it takes a little bit of training. So you need to make sure that they know how to use the pump and how to give themselves insulin, not to be dangerous. So we used to fill it with saline so that they can practice. They still give their injections. They're not going to make a mistake that's going to kill them, right?
Just placebo.
Yeah, placebo, exactly. Yeah, so that they get to use the function of the pump for 4 to 7 days, and then it's fine.
Insulin calculation, you have total daily dose
Yeah,
on MDI.
yeah.
This is to switch.
Yeah. So if you want to switch them from injections to pump, then you calculate all of their MDI doses together, basal and bolus, add it all up, total daily dose, minus 30%, divided half.
Reducing 30% injections.
Yeah.
Injection.
Yeah. So say they were on 10, 10, 10, 30, that's 60 daily dose total.
And so it will be 40.
Yeah, exactly. Yeah, so it would be 40 units total on a pump, and you would split it 50-50. You would do 20 across the course of the basal,
Yes.
and 20 split between 3 meals for bolus.
107 to 8.
Yeah, which is about 140, 150. So you set the targets higher for the first few days. Yeah, and then you bring it down, yeah, just so that they don't make mistakes and have low blood sugar. Yeah. Pardon? No, the pump only has rapid-acting insulin. So the way that it delivers basal, is it gives microdoses. So every 5 minutes it gives a very, very small dose of rapid-acting insulin. So that adds up to become your basal. Yeah. Yeah. Sorry, 180. So if a blood glucose is 180 for 2 hours, then we would say test for ketones. Because in pregnancy, DKA happens at much lower blood sugar levels. Yeah. Any other questions or comments about anything in diabetes pregnancy? Yeah.
We approve Levimir as a basal.
Yeah.
What about the other? Did you use in your country another long-acting?
Yeah, we use all of them really. We use Levemir, Lantus, Insulatard.
FDA approval and others.
Yeah, so we're a little bit less fussed about that. Yeah, there is less evidence about, say, Lantus, for instance, but there's no evidence to suggest that it causes any harm, and it doesn't cross the placenta, so there's no real biological explanation for it causing harm either. So we use it off-label. So, yeah, which is the same as metformin. So, yeah. So again, in our country, it's not so much of a problem. We can have that discussion with women individually and say, so there's a trade-off. If we want to use the one that's been tested most extensively in pregnancy, it doesn't get as good glycemic results. And so you can have that discussion honestly and say, we know that the slower acting insulins or the human insulin or whatever, you're not going to get as good glycemic control. And so most women are happy because they know that glycemic control definitely, hyperglycemia definitely causes harm. We know that. Whereas we think that the insulins are safe, all the evidence we've got. And there's enough women use them without any kind of problem that there's no indication that they cause any problem. But I think it is different in different contexts. If that's a restriction that you have to work within, then you have to just work with what you can do in each individual country. No problem. Yeah.
When you give carbohydrates, you give the evening the last carbohydrate more than the morning.
Yeah, I know. So I think for her it was because her starting was so high that she thought the ones I gave in the morning were unrealistic. But is that what you mean? The advice that I gave in the morning is different from this one? Or that they eat less in the morning? Yeah. 50-50, yeah. And in this morning I said 20 to 30, 40 to 50, and then 50 to 60. Is that what you mean? Yeah. So I think it was specific to that patient because her carbohydrate intake beforehand was so big that she refused to do our normal one. So the one that I said this morning is what we would usually recommend. 20 to 30 grams for breakfast, 40 to 50 for lunch, and 50 to 60 for dinner. This patient was a bit different because they were so unhealthy beforehand. They ate so much carbohydrate.
The normal for another pregnancy. It's
Without diabetes,
individualized, or you have to be certain.
everybody almost with diabetes or without diabetes. Yeah, everybody with diabetes, we pretty much say 20 to 30 for breakfast, 40 to 50 grams for lunch, and 50 to 60 grams for dinner. But with gestational diabetes, we're not very strict with the carbohydrate counting. So instead of teaching them to count carbohydrates, because we don't have so much time, we give them food ideas. So we say 20 to 30 grams, that's around one slice of bread. So you can have one slice of bread with egg and cheese or whatever. We talk about that rather than the carbohydrate allocations. With type 1 and 2, we talk about the carbohydrate allocations. Does that make sense?
Bonus for the carbohydrate ratio is 2 to 1 for the breakfast.
That was just for her. That is individual. The ratios are individual. Yeah. So do you have Daphne or some sort of structured program here? Ratios?
We know about
Yeah.
that,
But you don't have a...
not implemented.
Yeah. Do you have an equivalent? Anything like it?
Could be individualized according to the clinical
Yeah.
needs in certain universities or the
Yeah.
hospitals.
Yeah. Do people usually use ratios like this? Or they just have fixed doses?
Usually in the children or in pediatric
Yeah.
Clinics,
Mhm.
he's starting to teach them
Ratios, yeah. I think it's hard to change it all at once, isn't it? But over time, once these children become adults and adolescents, we'll have to get used to it. And I think actually in the long run, it's incredibly useful because it means that people can live much more normal lives and adjust their insulin themselves, even if they're eating completely different things on different days. So the ratios, I think, are really useful, but you can't teach it instantly. So it's worth, if you have an opportunity to even get the Daphne resources, there are other courses as well, similar, and you can read through them and then teach your patients if it's useful. But the talk Pratik did this morning gave some of the initial indications about how you calculate the first doses. Yeah, Dr. Chowdhury's doses were fine in terms of ratios. And then once you've got one that you start with, you just change it a little bit as you need to. Okay. Any other questions? Yeah.
Our previous knowledge about the time of administration of rapid-acting insulin
Yeah.
just before meal,
Mhm.
during or after meal, within a quarter of an hour.
Yeah.
Today morning, yes. Today morning,
Yeah.
I don't remember who was speaking about
Yeah, it was Dr. Chowdhury as well.
with quarter of an hour.
Yeah.
Quarter of an hour before meal.
Yeah. That's what we do as well.
This is a
New idea for you.
for us.
Yeah. Yeah, so it's because it takes some time for the insulin to absorb. And so, yeah, the onset of action is up to an hour. And so if you want it to act maximally, if you want it to be most effective, reducing that postprandial peak, then you need to give it earlier, because the insulin needs to be on board. It needs a head start because it's slow and the carbohydrate is quick. Yeah, so if you give it late, you'll just be constantly chasing. Yeah, so if outside of pregnancy, a quarter of an hour, 20 minutes before is fine. In pregnancy, that's fine for the start of pregnancy, and then by the end, you increase gradually up to 45 minutes before.
Also, our previous speaking about not for analogs, about human insulin we use
Yeah.
half an hour at least.
Yeah, so I think that would have to be even more. We're a bit out of practice with, yeah, human insulin, but we are a bit out of practice. We don't use it quite as much anymore. I think I would start half an hour, and then if you were using it in pregnancy, I would do the same thing. I would gradually increase just by 10 minutes until it seems better matched. So you can look at the postprandial peak, and particularly that pattern of a high after meal reading and then a low before the next. Try making it 10 or 15 minutes earlier before the meal and see if it helps. And you can keep extending it.
Why 45 minutes before meal in pregnancy?
So that's with a rapid-acting insulin analog. It's because at the end of the pregnancy, the insulin takes much longer to act than outside, and so you need to give it even more time. Exactly.
Pharmacokinetics of the insulin?
Yeah. Yes. Exactly. Yeah. So you have to gradually increase it, 45, because it takes up to an hour and a half to work. So they won't hypo 45 minutes before, because it's an hour and a half till it actually reaches its concentration. Yeah.
Okay, 1 hour after meal or 2 hours is most convenient for the GDM.
Yeah, we always do 1 hour. Most people find it more convenient because they're still in their house or whatever. An hour is not too bad. 2 hours they often forget. So it's also the best in terms of it's the highest blood glucose reading is 1 hour after. So we do 1 hour.
GDM, not
Yeah, both. We do both 1 hour.
both.
Mhm.
2 hours.
Yeah, we don't do 2 hours.
Okay.
But it depends what's easier, right? Some people would say 2 hours easier, some people say 1 hour. Yeah. The important thing is if you're doing 1 hour, you have a different target to 2 hours. Beyond that, I think each patient can choose, each doctor can choose, really. We do 1 hour, but some people do 2. Okay? Any other burning questions? Otherwise, I think it's dinner time, isn't it? Yeah. Yeah, start at night. Why? Because of the gastrointestinal symptoms. So they're less likely to feel nauseous when they go to bed. Whereas in the morning they feel sick anyway. Morning sickness in pregnancy, they feel sick anyway. So do it at night. Okay? Great.
Thank you so
Perfect, no worries.